So without further ado, I will turn this over to you.
Wonderful. Well, thank you so much for this invitation to be a part of this program. Fertility preservation is something that's very near and dear to my heart. So for everyone who doesn't know, I'm an OBGYN in the UNC OBGYN department, and I'm in the UNC Reproductive Endocrinology and Infertility Division, and so that's really specifically fertility and fertility-related issues. And then within that, I'm the director of the UNC Fertility Preservation Program, which we have out of our UNC Fertility Division as well. So thank you so much for the invitation. Hopefully this is a very helpful tool information for everyone in terms of what they can do for their patients as well. So in terms of things to cover today, first I'll just discuss the importance of conveying the risk of fertility to patients. And then we'll talk about the treatment options that are available for men and women, both before and after the cancer treatments. And then we'll also provide an overview of the fertility preservation services that we have if patients need them, or if you're curious about what those options are once patients do use them. So in terms of just the big topics of cancer and fertility, this is something that is becoming more and more pertinent to our clinical practice, both in the oncology world and the fertility world. And that's really because a lot of the cancer treatments are becoming much more successful in terms of survivorships and remission. And so over the decades, because of improved cancer care, we have many more survivors who are trying to plan their lives and continue with their lives and have a good quality of life in their survivorship as well. And because especially of the success rates of some of the pediatric or adolescent and young adult cancer treatments, we are seeing a large boom in the population of couples who are trying to build a family who one of them has had a history of cancer treatments in their past. And so with this growing patient population, we need to make sure that we understand the new and improving services we can have for them and what the options would be for this patient population. Next slide. In terms of recommendations for cancer patients and fertility, ASCO actually has a very explicit guide for this. And so ASCO says as part of informed consent prior to therapy, the oncology team should address the possibility of infertility with the patients as early in treatment planning as possible. And I'll talk about logistics as we go forward through this in terms of how we can help patients do this as quickly as possible. But this is really a nice support from ASCO in terms of the importance of fertility in counseling, and also the importance for the clinical teams to acknowledge this as something that needs to be a part of their counseling at the very, very beginning of their journey. Next slide. So what is fertility preservation? Some people call this oncofertility. We're moving more towards fertility preservation to make it more encompassing. But basically, this is fertility management for cancer patients of reproductive age, which is a broad umbrella that we'll dissect in detail. And it's really where both oncology teams and the fertility specialists will work together as a multidisciplinary team through both the issues of cancer, cancer diagnosis, prognosis, treatment timing, treatment type, and then working with the fertility team in terms of assessment of the patient's current fertility, possibilities of the effects of fertility, or excuse me, the cancer treatments on their fertility, options that individual patients have before and also after their diagnosis as well too. So it's really a big functional team to try and provide that care to patients. Next slide. So I'll break this talk up into two sections. One will be women and fertility preservation, and then the second will be men and fertility preservation. So I'll start with women first. It does tend to be a bit more complicated with some more pieces of it as well too. But we'll start with just women with cancer and how we can help them with fertility preservation. So to sort of set up the talk and how we kind of look at things for fertility, especially in this special patient population, what I have here shown is a graph, and on the y-axis on the left is the number of eggs in a woman's ovary, and then on the x-axis is the age of the woman. And what we can see with this blue line, even starting at age 0, so really at birth, the number of eggs a woman has will slowly decrease every day, actually. Slowly decrease as women move through their teenage years, their 20s, their 30s, or 40s, and as they move into menopause. And so when we take a look at this, and we consider what is the optimal age for fertility, that's usually sort of in our late teens to early 30s. because oftentimes we have a good number of eggs and a good quality of eggs during that time frame. And then once we move into their 30s to early 40s, we do see a decline in fertility, both due to decreasing number of eggs in the ovaries, but also decreasing quality of those eggs remaining in the ovaries. And then once we move into our 40s and early 50s, around the time of menopause, that's where we see really the end of fertility and the sort of window for reproduction closes. And again, that's sort of the double hit of very few eggs remaining, and of those eggs that are remaining, the quality of them is very poor. I do include over on the y-axis this term AMH in red. And what this is AMH is a blood test that can be drawn anytime in the women's cycle, anytime, night or day, and it stands for anti-Müllerian hormone. And it's a hormone that is specific to eggs in the ovaries. So only eggs in the ovaries will make this hormone and put it into the bloodstream. So it's very specific in terms of determining the overall reserve or number of eggs that someone has in their ovaries. So you'll hear me use this term as the presentation continues, and just sort of mentally note that AMH is a surrogate for the overall sort of supply and number of eggs that someone has remaining, and that's how we're able to help determine it and monitor it. Next slide. And we can move to the next slide as well. So whenever we think about the effects of cancer treatment on fertility, what I've done here is shown an example of, let's say, a 20-year-old female who at age 20 receives gonatotoxic therapy, so either chemo, radiation, or maybe surgery to her ovaries. And as you can see on the vertical dot line, what can happen is the number of eggs can be decreased due to that therapy. And we might not know how many, but as you can see, as we fall down, it drops the overall supply and really brings you down on that y-axis. And so what I show here is that, let's say when this patient has undergone gonatotoxic therapy at age 20, even if they're still getting periods, you can tell how they really drop the number of eggs they have remaining in their ovaries. And the slope of losing eggs will still remain the same. And so the age of menopause, or very few eggs, gets moved up by, a decade or two in this patient. And so it's something just to kind of think in our heads that, a cancer treatment or other therapies can actually still have eggs remaining, which might seem good at the beginning, but if the number is very, very low, that changes the outlook in terms of someone building their family as well. So we more so would think of this as premature ovarian aging in a sense, where we're actually moving up the time frame and shortening the opportunities and windows for women to build families with their eggs. And that can lead to infertility and also, of course, earlier menopause than they otherwise would have had. Next slide. So in terms of predicting, this is always a question that we get and patients ask, which I think is very pertinent, but unfortunately never has an exact answer for every patient, is sort of what is my risk with the treatment plan that I have for myself. And so there's a really nice tool that is part of the Livestrong website. The Livestrong Fertility Foundation or Cancer Foundation helps these patients immensely. And there's a very nice chart, which I've shown a picture here too, which on the very left shows degree of risk. And this is of amenorrhea, or not having any more periods. And you have high risk, intermediate risk, low risk, very low risk, or unknown risk. And then the second column has treatment protocol. So what types of therapies, what age woman, total doses of radiation, are they getting spinal radiation, how many cycles of certain treatments they'll get. And then the column on the right is the common usage in terms of clinical uses of this as well too. So this is something that's kind of nice to eyeball. It's not, it doesn't give you an exact number of 35% chance, but it sort of lets you group things into very high risk, intermediate, low, or unknown. So for example, if you had a 35-year-old woman with breast cancer and she was planning AC therapy, her risk of amenorrhea is pretty low. It's less than 20%. It's not nothing, but it's lower than some of the other ones. But really, the real question that people ask is, what is my infertility risk, or my chance of having, issues getting pregnant after this? And really, the chance of that is likely much higher. Next slide, please. You can progress through that. And really, this is because the return of periods does not mean fertility was unaffected. And so the reason why I'm really honing in on this point is that sometimes there's a false reassurance. If someone's gone through therapy and their period comes back, that their fertility must have been untouched and that their eggs and ovaries were unaffected by their treatments. But women will still have periods and they will still have cycles even if they have very, very few eggs left. So it's not really an accurate way of knowing what the reproductive future would be or their opportunity reproductive window would be as well too. Next slide. So as shown here is kind of a dramatic example of this. So still using the same graph where we have the y-axis of number of eggs and the x-axis is years. And so, for example, there's this patient who, was 20 when she got her gonadotoxic therapy, and let's say it, dramatically dropped the number of eggs she has, as you can see in that yellow starburst. So even if she has very few eggs remaining, she will still have periods. However, if we weren't doing any monitoring or checking, with AMH levels, she might be surprised in 2 or 3 years later when she stops having periods because she's now actually run out of eggs at that point too. So this is just a visual example of how we can uncouple the assumption of getting back your period means your fertility is fine, because those two don't actually correlate one-to-one. Next slide. Okay, so a poll over question here. When should providers discuss fertility preservation with patients? So should this be before a treatment plan is established, once the plan is established but has not started, after initiation of chemotherapy, during chemotherapy, after chemotherapy while they're in remission, or B, C, and D, or all of the above? Let's see what thoughts people have.
Yeah, so it looks like the majority answered A. Dr. Peavey, what are your answers?
Wonderful, yes. So the true answer actually is G, which is all of the above. Definitely, priority-wise, if we had to rank them in priority, A would be the priority before a treatment plan is established, because that is really the soonest that we can. But then really, for patients, it's something that is more of a continuing care. And so if we think about it, we monitor, cardiac function, during some chemos or PFTs, et cetera. This is sort of another end organ that can be damaged during chemotherapy. And so it's something where even if patients have missed, A, B, and C or D timeframes, E and F timeframes, whether in remission, or E while in remission, or in survivorship, those are actually really great times to discuss as well too. So it's something that overall can be a continued conversation, or if a conversation was not had earlier on, the time is always now. And so it's always appropriate for those discussions to happen at all those time points. Yeah. All right. And so one question that we do get often, both before treatment, but also women who are in survivorship, is what does pregnancy look like after chemotherapy? The great news is that there's a lot of data on this, and the data is very optimistic. It shows that that pregnancy does not trigger recurrence, even after breast cancer, and that's something that a lot of women providers are worried about, because, especially for ER, PR positive breast cancers, the concern is will pregnancy itself and the hormones of pregnancy decrease someone's survivorship or chance of recurrence. And fortunately, the data has shown that is not the case at all, which is great. Patients also ask about egg quality. So they say, okay, well, we know I have eggs left, but I had this, chemo treatment or this radiation. Does it mean that the eggs remaining in my ovaries are not good, that the quality is affected? And the answer for that is no. Egg quality has not been shown to be impacted by chemo radiation, just the quantity. So the eggs that are remaining, they are good in a sense, or they're not harmed by the treatments. It's just the number of them that can be decreased. And so you can just deplete the number of eggs available, but not the quality of those eggs. So it's not risky to use those eggs afterwards. Next slide. And so this is a really nice sort of summary chart, which we're going to go through in more detail about the fertility preservation and family building options for women. And so in the left column, we have the different types of therapy. And then we have if this therapy is available before, during, or after their treatments. And also if it's considered standard care, experimental, or if the data on it is lacking and it's debatable in terms of the impact. So what I'll be discussing further is embryo freezing, egg freezing, ovarian tissue freezing, a medication of GnRH agonists called Lupron, and then also, for some women after treatments, natural conception, using donor eggs or embryos, or adoption for family building. And so this is a nice summary of all the various options that are available to women and families after treatment and before. The one thing I do want to highlight at the bottom is that we do encourage all women who are diagnosed with cancer, who will be going any type of treatment, to have an AMH blood level drawn before treatment begins. And that's just a way for them to understand what their ovarian reserve was before treatments. Therefore, if they ever want to know the effect of their treatments, if they test the AMH level after, they can know how much of a drop they had or not at all during treatments, and can give them a better better knowledge in terms of how many eggs actually do have remaining, or how much your cancer treatment has affected it. So this is something that we've really been encouraging providers and clinicians to draw an AMH level pre-treatment as part of sort of some of your standard testing. All right, next slide. And I think we can advance. I think there's a pop-up here. Perfect. And so again, just sort of reiterating that when we look to the specifics for pregnancy, for cancer survivors, that children have no increased risk of birth defects, genetic diseases, or cancer risk themselves. So whatever eggs are remaining will be okay to use. The only cancer risk would be if there's an inherited genetic condition that might be passed on from mom to child. But otherwise, there is no increased risk to the child being born to a mom who's had cancer treatments. Okay, next slide. So what I'll chat with is some of these interventions we can do before, which is embryo freezing, egg freezing, and ovarian tissue freezing. So next slide. So I'll sort of frame it and just go through IVF in general, just for those not familiar with the process or curious about how the process works. And so I have some pictures demonstrating the process as well too. But basically what happens is for 8 to 12 days, women will take medications, and these are subcutaneous medications that they would give to themselves in the evenings for about 8 to 12 nights in a row. And so they are taught how to do them, but they would be doing them themselves at home for about that week and a half. They come in these pre-filled syringes with doses on them, and they would be taking certain doses of these medications every night. These medications are recombinant FSH and LH, and so these are hormones that every month, typically the brain sends down to the ovaries to grow just one egg in a typical cycle. But when you use higher doses of these medications during the IVF process, it causes the ovary to not pick out just one egg, but it picks out 5, 10, 15, or 20 eggs. And so that's how we really make it more of a robust process, because we use those medications. During that 1 to 2 week period, they come into our office for ultrasound monitoring. This happens about 4 or 5 ultrasounds over that week or two. So it's a little intense during that time because they're office fairly often. And we perform transvaginal ultrasounds. If patients are young or not comfortable with the transvaginal ultrasound, we can also do it transabdominally, but most of them are transvaginal. And so the second picture that you see here, that sort of gray ultrasound picture, is a picture of a stimulated ovary, and each big dark circle is a follicle. And those are nice, big, mature follicles that are ready to have their eggs removed from. So this is the type of pictures that we see during the egg growing process. Once the eggs are ready, they undergo one procedure at our clinic. It's an outpatient procedure and with an anesthesiologist, and they're sedated for about 20 minutes. And then a needle goes transvaginally via ultrasound guidance. In that second picture, you can actually see that sort of linear line and bright white line coming in from the top. And that's the needle that's coming in and going to that follicle and draining the fluid out to get the egg. It's simple to do. Again, it takes about 20 minutes. Patients are at a clinic for maybe about 45 minutes or an hour total, and then they can go on with their day. The great news is that they recover so easily that if they needed to be admitted for chemo that afternoon or that night, they can. There's no waiting period in terms of treatment after that procedure. This third picture is more of a diagram of how the ultrasound goes in the vagina and how a needle goes past the vaginal wall into the ovaries to take out those eggs. And then the next picture here is a picture of eggs under high-powered microscope. And so we'll talk about pros and cons, but you can either choose just to freeze eggs at that point. So at that point, the eggs are taken out or frozen individually as just eggs. Or if the patient wants to, and if they're partnered or have a sperm source, we would combine the sperm and egg together on the day that the eggs came out, and that would make an embryo, and then the embryo would be frozen. In the future, whenever the patient is ready to get pregnant, we would thaw an embryo and put the embryo in the uterus for the patient to carry. A common question that I get is how good are the embryos, or how long are the embryos good for? Is there an expiration date? Do they get freezer burn? Is there a certain timing? And the answer is that they are good forever. So as long as they're kept frozen, they can be frozen for 1 year, 10 years, 20 years, 30 years, and still have the same success of pregnancy no matter when they're used. So basically they're forever until patients need them. All right, next slide. And then next slide as well, go past that. So in terms of IVF with embryo freezing, previously, about maybe 15 or 20 years ago, the type of IVF protocols we used meant that it could take anywhere from 3 to 4 weeks to do the process of IVF with embryo freezing. And that was because the way that the protocols we used to freeze eggs and grow eggs was different. But now women can actually start any day of their cycle the process of freezing eggs. So if it's a Tuesday and they refer to us and they want to start Tuesday night, they can start Tuesday night. So it's something that does not need to be dependent on their period or where they are on the cycle. We can really just do it that quickly, and the ovary will grow eggs with the medication. And so it's a nice way to be able to offer this as a very quick process. And so you only need really 10 to 12 days. But early referral is key, right? It's easier if you have more time than to be crunched for time too. But fortunately, a lot of patients, can have a chemo 10 to 12 days later or 2 weeks later from the referral, and we're able to get an egg freezing or embryo freezing cycle and for them. This option is available for women after puberty, so pre-pubertal girls, this would not be a good option for. For the sperm, they can use their partner or donor sperm, and this also gives them a chance of future pregnancy. When we chat with patients, we always like to emphasize it gives them the chance of future pregnancy, but not a guarantee, because there's not ever a guarantee that those embryos will eventually, once they're transferred, turn into living children. But it does give them the chance, whereas otherwise, if all their eggs are depleted during chemo, that chance would not be on the table in the future. Next slide. So egg freezing. So egg freezing is something that is newer, but it's now actually standard of care. And so the way that egg freezing is similar is you go through the whole ovarian stimulation process. You take the injections, you do the ultrasounds, you have the procedure under anesthesia to extract the eggs. But once the eggs are extracted, that's where the process stops. They're not fertilized with sperm. They're extracted as mature eggs and frozen as mature eggs. In the future, if they want to use those eggs, we thaw those eggs and then combine them with sperm in the future to make embryos. So it's like they go through most of the process, but not all of it. It is not experimental. It used to be. I think in 2012, 2013, it came off the experimental designation list. And that's because it was previously challenging to successfully freeze and thaw eggs, but now with newer technology and newer advances, egg freezing and thawing is a standard, and we do this for many, many patients, even outside of cancer diagnoses. And so it's proven to be a very easy, simple, reliable process to do, and there's been thousands of babies born worldwide from frozen eggs with good safety profiles. So it's unfortunately another option for women as well. Next slide. So why might someone choose egg freezing over embryo freezing? One of the main benefits is it doesn't require a male partner. So a couple decades ago, if a woman wasn't partnered but wanted to do fertility preservation, she had to use a sperm donor and create embryos with a sperm donor. And while that was a good option, still not the best option for someone because it limits some of their reproductive choices in the future in terms of who they would want to bear a child with. And advance it. You can advance it again. It costs less, and so because you're going through not all the process of fertilization, making embryos, it actually is a lower cost up front. In the future, you would have to pay to turn those eggs into embryos, but initially it's a lower cost. And then some patients have either moral or ethical concerns about freezing an embryo, and for them, freezing an egg doesn't have those moral ethical concerns, and they're more comfortable having frozen eggs rather than having frozen embryos. And so we're seeing women choose this more often, actually, even when they are partnered, because they the outcomes are very, very good with frozen eggs, and they'd rather not have the decisions what to do with embryos in the future, which can sometimes be more burdensome than eggs in the future as well. Next slide. So in terms of other options, and this was in that big graph I showed at the beginning, is Lupron, which is GnRH agonist. And so what this is an injectable medication that basically turns off the pituitary, so no FSH or LH is released. And the reason why some people try and use this as a fertility preservation technique is the thought is that if you turn off signals to the ovaries might be quiescent during chemo, and if they're quiescent, possibly they won't get the effects of chemotherapy as much. So the reason why, though, this is still debatable and is unclear for the data is that there have been many RCTs, many retrospective reviews, a lot of pooled data, and it has not been clearly shown to increase someone's fertility. There has been some increase, very mild increased chance of your period returning, but as we talked about earlier, your period returning and fertility are not one-to-one. And so this is something where it's fine to use, but it really technically cannot go into the fertility preservation category because the data has been wholly unconvincing that it is a reliable way to save someone's fertility. Next slide. So people ask, well, should this be standard? Should we do it? Should we not? I mean, everything is, benefit, pros and cons. The benefit is that because the data is mixed, maybe there is some possible improvement to future ovarian function, or also because GnRH agonists and Lupron stop periods, that it's helpful to minimize menstrual symptoms during chemotherapy, especially people with high-grade thrombocytopenias who deal with heavy bleeding. This could be helpful just to prevent that symptom. However, it's not an entirely benign medication. People do have side effects on it. They can feel hot flushes, headaches, changes to mood, vaginal dryness. It's not completely benign. You kind of get thrown into mini menopause when you go through that. If it's not covered by insurance, it can be costly. And it also can be sometimes falsely reassuring. Some people can think, oh, I'm doing this for my, fertility preservation and I don't need to worry about it. And as I said, the data isn't very strong. So, that reassurance shouldn't really be there. A common question we get is when to start the Lupron. Again, the data is so kind of heterogeneous that it's really unclear when it should be started. But that would be something that if a team was questioning it, we could always help you guys answer that as well too. But typically, whenever someone knows they're going to be getting chemotherapy, you should start the Lupron and continue it during their chemotherapy. Next slide. Okay, so another clever question. Which of the below is a true statement? A, embryo freezing is medically superior to egg freezing. B, egg freezing is still considered experimental. C, women without a male partner can freeze eggs. Or D, all of the above.
Some answers coming through. Looks like 100% of answer C, women without a male partner can freeze eggs.
Would you like me to wait for more answers, Tammy, or are we good?
Yeah, look, oh, we got a few coming in, but what do you think, Dr. Peavey?
So C is correct, and that women without a male partner can freeze eggs. And so embryo freezing is actually medically equal to egg freezing. Egg freezing is not experimental anymore, and a woman without a male partner can freeze eggs. And so that would be our correct answer. Yeah. Okay. Options after treatment. So, as we talked about at the very beginning, when should fertility preservation be discussed, before, during, and after treatment. So, after, there's always a chance of natural conception. Women can undergo IVF with their frozen eggs or frozen embryos. They can undergo IVF if they still have eggs remaining in their ovaries. For women who can no longer carry pregnancy, they can use a gestational carrier or surrogacy with embryos or eggs they had frozen before, or they can family build with adoption. So all these are still can be on the table for a woman post-treatment. I'll briefly discuss gestational surrogacy a little bit in terms of how it works. So this is where one or more, usually just one, embryo is transferred to the uterus of another woman for a woman who's unable to carry a pregnancy. And so we see this most often, especially in the oncology world, for women who do not have a uterus because it was surgically removed, or for women whose uterus was severely damaged due to pelvic or abdominal radiation, or for women who it's medically contraindicated, like they're taking a medication that means that it's unsafe for them to get pregnant. In these cases, women and couples can use a gestational carrier for their pregnancy. Next slide. So now I will move on to options for men. Fortunately, the process for fertility preservation for men is more straightforward and simpler. So it's logistically easier and also has less of a financial burden. But to summarize some of the options for men, again, a very similar table here. Men can bank sperm, which means they can freeze sperm before or after their treatment. If they're unable to produce an ejaculate sample, they can have a sperm extracted before or after. They can have immature testicular tissue, like a piece of the testicle frozen beforehand, which is still considered experimental. And then after treatment, they could consider natural conception if they still have sperm left, or they can use sperm that they froze. They can use donor sperm or build their family through adoption. Next slide. And so I'll chat a little bit about some of the terms that you might hear us use when we chat about male fertility. So there's IUI, which is intrauterine insemination. And I'll go through in detail what that involves. IUI needs the most number of sperm available to be successful. Then there's IVF, or in vitro fertilization, which is, as I described earlier, a woman grows eggs, has them extracted and combined with sperm. So even if the woman doesn't have fertility issues, but her partner has low sperm counts, IVF can be used. And within that, there's a process called ICSI, ICSI, which is intracytoplasmic sperm injection, where men who have very, very few sperm, so maybe like 20 sperm as opposed to 75,000 or 5 million, we can actually place sperm with a very, very tiny needle inside of the egg tube to help with fertilization. So these are all reproductive techniques that we use in this patient population. Next slide. So for intrauterine insemination, also called IUI, it's also been called artificial insemination, although that term has not been used as recently. This is where sperm are washed and prepped, and for a woman, whenever she's ovulating, she comes into clinic for this procedure. It basically feels like a pap smear for a woman. There's no anesthesia, there's no pain, no discomfort. And a very tiny catheter is placed past the cervix all the way to the top of the uterus, and then with a very small syringe, the sperm is injected to the top of the uterus as close to the fallopian tubes as possible. And so by doing this, it increases the number of sperm that gets the egg by like 50-fold or 100-fold. And this is used for male factor frozen sperms where they have good sperm counts, or sometimes we'll use it in our clinic if people have unexplained infertility. So this is an option when men have banked a good number of sperm before their chemotherapy. Next slide. So logistics for sperm banking. And so this is where I also do want to give a shout out to Jordan Lodato Hunt, who's our fertility preservation clinical care coordinator, because she helps with all these logistics, because that can be a barrier as well too. But for sperm banking in terms of logistics, this is medically a simpler process than it is for women, but still requires sort of a team sport for this as well. So If patients are inpatient, then providers can contact our fertility preservation clinical coordinator, and the providers would also help by ordering required STD labs, which is what the sperm banks need in order to help bank the sperm. And then the patients, we can help schedule the appointment for the sperm drop-off, help them complete paperwork, help with the logistics of collecting a specimen in the hospital, which can have its own barriers too, and then help with the logistics of transporting the specimen to the fertility center, which is either by courier or family member. For outpatients, providers could contact our fertility preservation coordinator. They could help order the labs, or the labs can be drawn at UNC Fertility on the day that the men bank. And that's actually the simplest way to do it. The patients themselves can call and schedule an appointment and complete the paperwork, and then they would provide the ejaculate specimen at the outpatient clinic. So this would just depend on the health of the patient and where they are at the time that they would like to bank sperm. But just for everyone to know, this can be done no matter where patients are located, inpatient, outpatient, we can help do both. Next slide. So, one of the urgent calls we get is, let's say we have a 21-year-old man admitted for ALL, and he's needing to be inpatient and start chemo tomorrow or the next day, and he can't discharge himself and go drive to the outpatient clinic and give a sample. And so we do have a lot of consults from inpatients. And so what we do is we help coordinate the specimen collection for the patients to do themselves in their room. And so this is where things, I think for folks who do this often can feel awkward, but we kind of try and mentally reframe it as it's sort of a medical procedure, something we're all comfortable with. Embrace that it's weird to ask a male patient to ejaculate in his room, right? And so it's something that we just kind of have to go in and try and make the most comfortable situations possible. And so there are collection cups on the inpatient units for this purpose. And then really it either takes, the nurse or the clinical team to say, okay, we're gonna clear the room. There's, a sign on the door to not be disturbed. And then with the patient determine when it's okay to come back in the room because someone will have to pick up that specimen and then take it over to the clinic for freezing. Okay, next slide. There are instances where the patient cannot produce an ejaculate sample. This could be adolescents or teens, men who have changes in their hormones, nerve damage, ED at baseline, or just emotional inability. It's a very strange thing to ask someone to try and do in the middle of a very stressful situation of their inpatient admission. But you can do penile vibratory stimulation, electroejaculation, or sperm extraction with our urology team. Next slide. So what if the patient is azoospermic or there's no sperm? So let's say they give an ejaculate sample and there's no sperm on that sample. This does not close the door completely. If there's timed availability, you can actually oftentimes surgically extract sperm with our urology team, where they would anesthetize the testicle and go in surgically and remove the sperm straight from the testicle. And so this can be done in survivors who don't have sperm on their semen analysis, but we think they might actually have sperm in their testicles. So it's never an end. They should be evaluated to see if we can surgically extract sperm for them in the future. All right, next slide. So male fertility after chemotherapy, we recommend that fertility is assessed about 2 years after treatment ends, and we can do that with a simple semen analysis at our clinic. If no sperm is present and they don't elect or they're unable to do a biopsy of the testicle, they can always use frozen sperm if it had been saved ahead of time. If they do repeat semen analysis and the sperm are present and appear in good form, then they can use try natural conception for them, or they can also do sperm banking if they're worried that they're going to need a future treatment for cancer that is going to, again, maybe get in the way of their fertility. Next slide. All right, it's another poll everywhere. What options are available to men for fertility preservation and family building? We have outpatient sperm banking at UNC Fertility, consultation without sperm banking, surgical sperm extraction by urology, use of a sperm donor if no sperm are available to be frozen ahead of time, or E, all of the above.
So while you guys are working on answering this question, just remember you can use Poll Everywhere to submit questions for Dr. Peavey. So please feel free to start entering them and we will go through that. So it looks like all of the above, E, the popular answer.
Wonderful. That is the correct answer. So all these options are available to patients. So it's just good to know that there's many different ways to go about this. That's perfect. Time needed for sperm banking. So unfortunately, we usually can't do this on the weekends. It's Monday through Friday, but we are open, during a wide swath of the day. Appointments must be made in advance, but they can often be available that same day. We just don't want people randomly coming by the clinic with a sperm sample to freeze. They actually have to be, have an appointment made and registered in our system. And then the easiest way typically for inpatients is for the sperm specimen to be delivered to UNC Fertility by a loved one. But again, we'll have that coordinated and we'll know to be expecting, the patient sample and who the patient is as they're registered. If they want to surgical sperm extraction, then that would require a formal urology consult. All right. So in terms of costs from here, this is these are sort of the no insurance costs for some of these things. So for embryo and egg freezing, if they get no financial help at all, it could be, $10,000 to $15,000 or $8,000 to $12,000 for each of those. However, there are several financial programs that we help patients apply to that can markedly reduce the cost by like $5,000 or $8,000 per treatment. But unfortunately, especially for embryo and egg freezing, which the cost is these still can be several $1,000s out of pocket for patients, even if these programs do help cover. Some insurances do cover embryo and egg freezing and IVF. So if that's the case, then the cost is nominal to patients. But if they don't have insurance coverage, it can be about $4,000 to $6,000 max out of pocket. Sperm making is about $141 plus storage. Insurance often does not cover that. Donor sperm, eggs, and embryos, these can be $3,000, $5,000, $10,000. Adoption, of course, is also expensive as well. And then gestational surrogacy can run up to $20,000 to $100,000 for that too. So this, is a barrier that we acknowledge and we try and work on with patients. All right, next slide. And so for the barriers that we hear from providers, but also from patients, is treatment timeline, cost, logistics. So I'll go over how we try and defray each of those barriers. Next slide. So for treatment timeline, we've, especially with Jordan Lodato Hunt being our fertility preservation clinical care coordinator, if she's contacted, we can often get, she will be in touch with them that day or within that next day too, and get them into our system and figure out what they need or what they want to do. Costs, we help with cost reducing programs such as the Livestrong and Walgreens Heartbeat, help them apply and do the paperwork for that. And then for logistics, what we've tried to do is really make a good bridge between the oncology teams and the fertility teams with our fertility preservation coordinator, Jordan, who helps really manage all these really difficult moving parts and time-sensitive parts as well, too. Next slide. So kind of, what are the ways that we can utilize it? So what I always encourage patients or providers to do is discuss the treatment's likelihood to impact fertility with their patients. Discuss if they're interested in learning more about it, and if they are, connect them with our team, and we can kind of take the baton from there. And so the point of it is also to take some of the burden off of the clinicians and providers, so that if a patient is curious or interested after you broach the subject, that we're able to take it to the next step. Next slide. I'll go through the next slide as well. So sort of in summary, the fertility preservation opportunities are essential with cancer treatment for men and women. Fertility can be preserved in a majority of post-pubertal patients, and all patients hopefully should be receiving this counseling or opportunity for counseling if they would desire. Next slide. This is sort of, how do we get there, right? How do you contact the fertility preservation team? And so many different ways. So we have a fertility preservation pager, and so that's through the WebEx and the paging system. Jordan is also available via email, available through Epic, although that's a little bit harder to be as urgent. And there's also a phone number as well too. So we try and make it the easy button so that once patients say that they are interested in learning more, that we're able to access them and give them the counseling that they would need to make decisions. Okay, next slide. At this point, I'd love to hear any questions or sort of chat about this further. So thank you guys. And team, I'll just leave it up to you to moderate any questions.
So we're waiting for questions come in. Remember, poll everywhere. You can type your question through that, and we can ask Dr. Peavey. We have just a couple minutes left while we're waiting for questions. Yeah.
These are just extra slides, Tammy, in case people have extra questions. So feel free to exit the, yeah.
So a question that came through, can a NovaSure procedure be successfully reversed?
And so that is where the uterine lining is ablated, and the answer is no. That whenever people have that, they should be counseled that that is that pregnancy is not possible after that, and it cannot be reversed. It's permanent. Yeah.
I have a question. When thinking about the role of fertility preservation in cancer patients, I know you talked about programs that could help with cost. Do you find that fertility preservation for cancer patients either is covered more so through insurance or special programs? It doesn't matter the reason. Just curious.
Yeah, insurance very, very rarely covers this. It is like a golden gem when we have a patient whose insurance covers this, even if it's because of cancer. And so there's been a lot in terms of legislation trying to make it be mandated, but it is not. Yeah.
Yeah, that's challenging.
It is. It's a very for patients who are motivated and want to do it, and it's sticker shock, unfortunately. And so the program's decreased by thousands of dollars, but obviously, $4,000 is a lot to ask of a patient to pay.
Yeah, sure, especially in light of their cancer therapy costs, right? Yeah. So we are about at the top of the hour. If there's any last minute questions coming through. Okay. I think one's coming through. 1 second. Oh, here it is. How are places like CNY Fertility able to charge much less for fertility preservation services?
Oh man, that is a very loaded question. CNY advertises themselves as the lowest cost IVF in the country, and there are reasons why it's lower cost, and I can't get into dicey. I cannot comment on that. Sorry.
No problem. And there's another question about costs and talking about grants specifically for costs, but I think you've commented on that. I don't know if anything from a grant perspective you have to add.
Yeah, so it's, there's the Livestrong Foundation, the Walgreens. Walgreens helps with meds, and Livestrong helps with the procedures of doing it. And so those defray the costs a lot. But, we're trying to work on our UNC philanthropy to, for people who are able to, have a UNC grant program, but there currently are not any, no national ones and no local ones.
Great. And then for our pediatric oncology colleagues, how young of a patient should we start addressing this with?
Yeah, so in terms of freezing eggs and embryos, they have to have, either start their period or maybe they're about to, like they've had some pubertal development for those options. But oftentimes, especially for young patients, who are 2, 3, 4, 5, 6, who, they themselves are not asking these questions, of course, if their parents are interested. A lot of this, and as Jordan will attest to, is parents just wanting to know what to expect, what the options are. I know that they looked down every avenue that they could because we're not able to freeze eggs or embryos for prepubertal patients. There is ovarian tissue freezing, which is still highly experimental and was done at a couple centers across the country, not ours. But that's something where if they were highly motivated, they could go to Philadelphia and Chicago, the closest places that do that for prepubertal patients.
Great. Well, thank you so much. This was really great and helpful and informative. So thank you for sharing.
Thank you for having me. This is it's such a wonderful topic to talk about. And hopefully, if anyone has questions, further, feel free to contact me or Jordan Lodato Hunt with our program.
Great. Thank you so much.
Thank you.
And thank you, everybody, for joining for our talk this evening. Again, check us out online, unclcn.org. We have upcoming lectures, including breast cancer management in North Carolina, as well as addressing cognitive dysfunction in patients with cancer. Next month, our advanced practice provider lecture is on oral complications from cancer therapy. And a reminder, some of our self-paced online courses are now available. Recent ones are COVID-19 and oncology, exercise and wellness as part of cancer experience, and immune-related adverse events. Thank you. Have a great evening.